Kia ora everyone. This recorded lecture is in case you could not attend my live lecture. Let's start. I know that you have learned about colon cancer and polyps before in ELM2. I'm not going to revise all of this material. Nada gave you excellent notes, and I hope that with a small amount of revision, you will be able to remember it. If you do need revision, then on CuraCloud, there is a video that will help you revise. So the key messages from this prior learning was that the majority of colorectal carcinomas arise from benign colonic adenomas, that there is a classic adenoma carcinoma sequence, and that is driven by APC gene mutations. APC is a tumor suppressor gene. It acts in an autosomal recessive way, i.e. both alleles need to be mutated for it to lose function. And patients with familial adenomatous polyposis already have one mutant allele, which means they get thousands and thousands of polyps. Any one of the polyps that are generated in FAP can become malignant, meaning that colonic carcinoma is inevitable for people with familial adenomatous polyposis. Let's move on to the second most important pathway for generating colonic carcinomas. That is the DNA mismatch repair pathway, called HNPCC, hereditary non-polyposis colonic cancer, or Lynch syndrome. Let's remind ourselves what is a colonic adenoma. Here is normal colonic bowel mucosa. We have nice crypts lined by cells that are small and confined to the base. But here we can see that the cells have piled up, forming a polyp, and they're hyperchromatic and crowded. These can either be tubular, forming a tubular adenoma, or they can form long finger-like villi. Knowing the morphology is important because they have different risks of going on to cancer. This is low with a tubular adenoma and much higher with a villous adenoma. How do these colonic adenomas become malignant? They go through a series of steps. The first step is that they move on to high-grade dysplasia by collecting more mutations such as KRAS and P53. The founder mutation, remember, is APC. Then, after that, they start invading. They get the ability to invade down from the high-grade dysplasia here in the polyp into the underlying stroma. This is to help you recollect the staging of colorectal cancers. We use the TNM staging system for colorectal cancer. The Duke staging system is not used by pathologists in this country. The staging is dependent on how far through the wall the tumour goes. So most tumours are diagnosed at stage 3, where they've spread right through the bowel wall and are in the subserosal tissue. At T4, they have spread out into the peritoneal space, i.e. through the serosa. And then N1 means they involve the lymph nodes, and then there's distant metastases. So let's consider what we actually need to know in ALM. We have to know about some more types of polyps. We have to know a bit more about colorectal carcinoma. There is the classic things that we always need to know in colon cancer that I explained to you when I was discussing about illness scripts. But we also have to be able to interpret the lab reports, tell the patients about their disease and plan their management based on the lab report, use your pathology knowledge to ask the right history, and to help your pathology use your pathology knowledge to solve problems about these cases. All right, so at the end of this lectorial, I really want you to be able to tell a patient how colon cancer develops. I want you to be able to interpret a pathology report and tell the patient which each part means in language they can understand. And also, I want you to be able to understand why an oncologist will choose different treatment options for each patient. So a step on from just knowing the knowledge about pathology, we're now into doing. Let's have a think about a case. So this 57-year-old man develops colon cancer. He's concerned about his future, but is terrified that his sons might develop colon cancer. He asks what can be done to reduce the risk. So let's do a knowledge review. Who is at risk of colon cancer? And what are the 4 molecular pathways that lead to colorectal carcinoma? So if you were watching this in class, I would get you to talk to each other and work that out. But what I want you to do now is to pause the video and try and remember who is at risk of colon cancer. If you find you can't answer that question, what I want you to do is either look it up online or go back to your previous notes. Okay, now that you have done that and remembered who's at risk of colon cancer, I want you to remember everything you can about the pathogenesis of colon cancer, especially the 4 molecular pathways that lead to colon cancer. You may not remember this very well, so I actually suggest you go to Wikipedia and look in Wikipedia about the 4 molecular pathways that lead to colorectal carcinoma. Pause the video and do that now. You've probably realized by now that I'm not just going to sit here and give you all the answers. You won't learn anything much if I do that. You can go and look for the answers in the pathology notes, your old notes, or online, for example, Wikipedia, like I suggested. If you come to class, we will be doing those exercises live with you. Okay, so why do you need to know who's at risk for colon cancer and how it develops? Well, you're going to be advising people all the time on how to prevent colorectal cancer and whether they're at risk of getting them. We want you to understand reports. We do a lot of molecular work in colon cancer reports now. Particularly, we include information about the molecular pathway that we use to diagnose the cancer. This is because the molecular pathway actually is used for treatment. We want you to understand colon cancer screening, and we want you to know who to refer to the New Zealand Familial GI Cancer Service. Now, you won't know who these people are at the moment, but hopefully by the time you've finished this session you will. If you don't, then just email me. Okay, let's carry on. So we've learned about the APC pathway. This is the pathway that 70% of carcinomas develop from. There is a initiating mutation, the APC mutation, which causes dysplasia in polyps, and then further mutations such as KRAS and P53 lead to progression through adenoma and carcinoma, and then eventually metastatic cancer. The next important pathway is the DNA mismatch repair pathway. So let's have a think about that one. The DNA mismatch repair pathway, what you need to know is there are proteins called mismatch repair proteins, and they exist at the DNA replication site. And they are in charge of repairing any mistakes that happen in DNA. So that if there are mistakes that happen in DNA that aren't corrected, and they are in a tumor suppressor gene or an oncogene, then that can lead to a step on the pathway to cancer. So if people's repair mechanisms aren't work, for example, through microsatellite, through the DNA mismatch repair pathway, then they will accumulate many, many mutations. And this will allow them to get colon cancer. So let's look at some more details. All right, so there's 5 things that you need to know about this mismatch repair complex. The first is that there are 4 proteins, 1, 2, 3, 4. And the second thing is that there is a promoter which switches these proteins on or off. This is meant to be like the off switch on the computer. The third thing to know is that if any of these proteins are mutated, then the whole thing doesn't work. The fourth thing to know is that if this promoter is methylated, it can switch off the pathway, and so the whole pathway stops working. And the fifth thing to know is if there are mutations in these proteins, they are autosomal dominant, and that will be passed on to the next generation. Now that was quite complicated, so let's take a moment to think about it. What would happen if the MLH1 was mutated? If the MLH1 is mutated, then the pathway doesn't work, and people have a very high risk, more than 60% chance of getting colorectal cancer during their lifetime. So let's look at the third pathway. So the second and third pathway are kind of related. We've got the FAP pathway, the APC pathway rather, which is the cause of familial adenomatous polyposis and 70% of sporadic cancers. We've got the gene mutated pathway in one of the mismatch repair genes, which is, 15% of cancers. We've got this pathway, which is about another 15% of cancers. So in this pathway, what happens is the on-off button that controls the DNA mismatch repair is methylated, these are these black dots, and switched off. So the whole pathway doesn't work. So they then progress through gaining mutations in oncogenes and tumor suppressor genes and developing colon cancer. How does it get hypermethylated? Well, methylation of genes is influenced in the gut by diet and the biome, because this exposes them to different chemicals. It can also be influenced by people's genetic tendency to hypermethylate. And so these kind of cancers are the same kinds of cancers that you would get with DNA mismatch repair mutations, but they're caused by a different process. So this last pathway, the MAP pathway, it is very rare, and actually you don't particularly need to know about it, not like the other 3 where you really need to know about it. But it is, again, another way of getting an inherited bowel cancer, because it, again, results from 2 mutations in this gene here, the MUTI gene, and about 1 to 2% of the general population carry a mutation. That's all I'm going to say about that one. So now we come to an exercise that we would do if we were in class, but we're not, we're online. So people might think, how does the environment cause colon cancer? And in this exercise, you were going to just shout out your ideas, and I would discuss them about how various things can decrease or increase the risk of cancer. So what I suggest you do, rather than shout them out to us in class because you aren't there, is actually just look online. Work out how a high fiber, low red meat diet, low alcohol plus exercise can prevent colon cancer. I'll give you a clue. It's to do with colonic transit time, which can be shortened by high fiber and exercise. It's also to do with what carcinogens are generated in the colon by what you eat. Okay, so let's put all this together now. So the patient is, again, remember this 57-year-old man, and now you should be able to explain why his son should modify their diet and improve their exercise. Maybe something like this. A lot of colon cancer can be caused by what is in your colon. And you know what's in your colon is basically what you eat. So what you eat can be digested to form some cancer-forming chemicals. It kind of depends on both what you eat and what kind of bugs are growing there. But the cancer-forming chemicals can act on the cells lining the gut and cause them to get mutations, which can accumulate and cause cancer. It also depends on how long things stay in the gut to cause this bad change. So if people exercise and eat high fiber, it rushes the digesting food through, so it doesn't have time to form these chemicals. So what we want to do is to have a diet that will make sure our bowel movements are moving through. High fiber, things like whole meal grains, beans, legumes. We want to reduce the kind of food that will cause the formation of these cancer-forming agents. Things like preserved meats, like bacon. I know, bacon, eh? And red meat. And then, by modifying that diet, they will reduce the amount of chemicals in the diet and in the colon, and also decrease the time that they're in there. How was that? It was a bit off the cuff. I need to practice too. Okay. So the second exercise that we did is thinking about a patient who's now 37 years old and has colon cancer and is concerned why his sons might develop it. Now, he's much, much more likely to have an inherited cancer at 37 than someone who's 57 and has had time to have had sporadic mutations accumulate. All right, so the patient is now 37 years old and likely has a mutation or a series of mutations that increase his risk of cancer. It means that he needs to have colonoscopies perhaps every year, and his sons will need to have colonoscopies if they are shown to carry the gene. So there's an organization that will work with this 37-year-old to determine whether he carries genes that can be inherited, and also to arrange colonoscopies for him and any relatives that are at high risk. And that organisation is called the New Zealand Familial GI Cancer Service. They are informed if the patient has been found to have a cancer that suggests he might have a familial cancer. The person who does this is the person who does this is the surgeon who is in charge of the case after it's been discussed at the MDM. Usually an MDM is a multidisciplinary meeting that radiologists and pathologists and clinical doctors go to plan the treatment for patients. So in one sentence, I would say perhaps something like this. Having a parent, brother, sister, or child with cancer may increase your chance of developing a cancer, particularly if they were young when first diagnosed. In a small number of families, there is an inherited mutation that increases your chance of developing cancer. It's important that you seek expert advice on the likelihood of developing cancer for you and other family members. If you're at risk of cancer, there's a free screening program that can detect the polyps and remove them before they develop into cancer. Okay, next slide. Okay, there is the thing that I just read out. And you might add it's free. It's free. Yay, it's free. Okay. So I mentioned the polyps there before cancer. So the patient might well ask you, tell me about the polyps that develop before cancer. All right, so live, we would get you to write everything down that you remember about colonic polyps. So stop the video here and go on and then write everything you remember about colonic polyps. Okay, so hopefully you could recall the polyps found in the APC chromosomal instability pathway. So those are tubular adenomas and tubulovillous adenomas and villous adenomas. I know you've covered all those before. However, there are polyps also associated with mismatch repair gene abnormalities and hypermethylation. That's the thing that switches off the mismatch repair genes, and they are large serrated polyps. There are also small non-serrated polyps that everyone gets called hyperplastic polyps, and they aren't associated with cancer. And then there are a couple of other non-neoplastic polyps that you need to know about, like juvenile polyps and Peutz-Jeghers polyps. So all these things are polyps. So the important thing is when your consultant on the ward round says, tell me about colonic polyps, you don't just stop at the adenomas. You can say that there are lots of kinds of polyps, including adenomas, serrated polyps, hyperplastic polyps, and other rare polyps like juvenile polyps and Peutz-Jeghers polyps. And then he'll think you're very clever, but could ask you a bit more about those things. All right, so here's a key fact. Some polyps are higher risk than others. So what are high risk polyps? So average risk polyps are your ordinary tubular adenomas and big hyperplastic polyps and sessile serrated polyps. They're the ones that are due to methylation or DNA mismatch repair. So they're average ones. Now, as polyps get bigger, they get higher risk. So anything that's larger than 10 millimeters, or anything that has a villous histology, or anything that has high-grade dysplasia is a high-risk polyp. And then the serrated polyps, anything big or anything with any dysplasia, or these other kinds of polyps with dysplasia are high risk. So your surgeon will know that. The New Zealand Familial GI Cancer Service will know that. Now you know that. So try and remember 10 millimeters, villous, high-grade dysplasia, or any sessile serrated lesion with dysplasia is a high-risk lesion. When polyps are discovered in people's bowels, often with the bowel screening program, they are classified into risk categories that allow people to that allows the program to determine when people are recalled. Most people will have a couple of average risk polyps and so should be rescreened in 10 years. With more polyps, you have shorter rescreening. With high risk polyps, you have even shorter rescreening, and with lots of polyps, you have to come back every year. I don't think you need to remember the specific figures, just the idea of the type of polyp and the number of polyps affects the screening interval. Okay, so what is serrated polyposis syndrome? You've heard of familial adenomatous polyposis, where people get hundreds of with conventional adenomas. So serrated polyposis syndrome is a syndrome where people get lots and lots of hyperplastic or serrated polyps. It is due to a combination of genetics and environment, and is more often seen in European people. Okay, so 1 in 3,000 people may have this condition. It's probably it's probably more than that actually. I think this is probably underdetected. And half of the people with cest-ulcerated polyposis have a family history of bowel cancer. However, genetic testing is not done because the genetic risk occurs over many genes, each contributing a small amount to the risk, rather than a single gene that's mutated. It is associated with an increased risk of bowel cancer, about 40% lifetime risk. And so these people have multiple serrated polyps. Okay, so let's have a think about which category you're going to put each of these people in. So this is interpreting the pathology report, right? Sections show 3 tubular adenomas with low-grade dysplasia, all less than 5 millimeters in size. So what you need to do is go back to the table and work out the right answer for this person. Clearly, this person's got a big serrated polyp. This person has got multiple small hyperplastic polyps. And this one has got a villous adenoma with high-grade dysplasia, highly suspicious for invasive tumour. So when you see this, what you don't do is refer them back to the screening program. This person needs to go straight to a surgeon to have that investigated. All right, let's see if we can interpret this report. Here we go. So the specimen is labelled as, here we go, a low anterior resection. So that means that the bowel has been taken out, the whole distal part of the bowel has been taken out, right down to the rectum. And all of the colon has been taken out. There's a tumour in the rectum. The tumour is 5 centimetres in diameter, and it is 15 millimeters from the cut end. This is the distal end of the resection, which is generally a good amount. You don't particularly want anything less than 10 millimeters clearance. So the tumour appears to be confined to the bowel. It's not perforated, and sits astride the peritoneal reflection. Okay, so remember the peritoneal reflection is different anteriorly and posteriorly on the rectum. So thinking about coming down just between the bladder and the rectum, you can see whether the tumour is astride, below, or above it. Why does it matter? Because if it's like below the peritoneal reflection, it doesn't have a peritoneal surface that will block its spread. It can just kind of go straight out into soft tissues of the pelvis. All right. In the peritoneum, tumour has formed nodules discrete from the tumour mass along the serosal surface. This means that the person who's examining in the lab is examining this bowel macroscopically, can actually see nodules. Okay, they're submucosal nodules. Yeah. And they're quite close to the distal margin again. Right, the tumour appears ulcerated, and it's scarring. It's pulling the colonic tumour, sorry, the colonic serosa in. But it appears shiny and doesn't appear to have perforated. So that's what we've got so far. So there's quite a lot of information that you get from these reports. You have to just like think about it and draw a picture. What's next? All right, so now we come to the microscopy. Right, so histologic tumour type, adenocarcinoma. NOS means not otherwise specified. So it means it's not a special kind of adenocarcinoma like a mucinous or a signet ring cell carcinoma. Histologic grade, high grade. So tumours come in 2 grades. They come in low grade and high grade. We grade the tumours depending on the amount of gland formation in them. So a low grade tumour will have lots and lots of glands, whereas a high grade tumour will be much more solid growth. And this reflects the biological potential of the tumour, where the higher grade ones will behave more aggressively. Right, the extent of invasion, this is how far through the wall it's got. It's the T part of the TNM. there's invasion through the muscularis propria into the pericolorectal tissues, right? So it's gone through the bowel layers, it's gone from the mucosa through the submucosa, through the muscularis, and is sitting in the subserosal pericolic tissues, but isn't quite through the serosal surface, which makes it a T3. And it extends 4 millimeters beyond the muscularis propria. There's some vein invasion in the wall, so this is again a bad prognostic sign that we look for. It means that it is in vessels and has probably spread out of the vessels. It's in the veins drain to the liver. So at the MDM, the person would have a CT of the liver to see whether or not there's any cancer there. Perineural invasion, this is invasion around the nerves. This is particularly important for rectal tumours because if they get into those nerve sheaths, they just wiggle along it and go a long way, all right? And they end up in the perirectal tissues, a long way from where the tumour started, and can be difficult to resect. So lymph nodes, we had positive lymph nodes in the perirectal lymph node basin. 2 of the lymph nodes had tumour out of the 14 that were found. So it's always one of the standards we meet is that a minimum of 12 lymph nodes must be examined. And that means that we've had a good collection and are likely to have identified any metastases. The apical node involvement right at the drainage point of the bowel where it's been resected is absent. Okay, so the thing that we had that were tumour deposits, we actually didn't confirm those as tumour deposits from that were seen in the macro. We'll come down to this later. Okay. Tumour budding. So what's tumour budding in these reports? Well, at the edge of the tumour, right, little bits can break off like this and go down. And if there's lots of tumour budding, it means it's behaving in a biologically aggressive way. Here we have response to neoadjuvant treatment. So what is neoadjuvant therapy? So neoadjuvant therapy is where people get chemoradiation before they have the tumour removed. And this shrinks the tumour down. It means that the margins are much easier to be resected, but this person didn't have any prior treatment. The margins were not involved. So the longitudinal margins, this is the proximal and distal margins, were not involved by 9 millimeters microscopically. So it was 15 millimeters macroscopically, but it's 9 millimeters macroscopically. The circumferential margin is the margin around the rectum here. Remember, it's below the peritoneal reflection. So there's a cut margin, and that was 13 millimeters, which is acceptable. There are no distant metastases. Polyps were seen, but this report isn't specifying what kind. And it appeared to be a complete resection. So all the colon cancer's out. But also the submucosal nodule that was found in the macroscopic examination and biopsied is a completely different tumour. It's called a carcinoid tumour. So carcinoid tumours arise from the neuroendocrine cells of the bowel. The neuroendocrine cells are part of the innervation of the bowel. Sorry, the neuroendocrine cells are derived from the embryologic foregut and secrete hormones. Okay, they mainly secrete things like serotonin. And it's a very small tumour. This tumour is unlikely to be of risk to this patient. Okay, so how are we going to stage this person? He's got a T3 at least, yeah. T3. He's got an N1, right? Because he's got 1 to 3 regional lymph nodes. So this is what he's got here. T3, N1, M0. Okay. And the surgeons will put all that information together and give it a stage. This is the AJCC stage, the American something cancer stage. Sorry, I've just forgotten what it stands for. And so I would call it a T3, N1, M0. And altogether that would make him a stage 3B, and that would influence his treatment. So hello, so what we're going to do now is look at the diagnostic coding. So at the end of every report will be a diagnostic summary where it states what tissue has been taken and what the diagnosis is, in this case rectal adenocarcinoma NOS. And here it's stating the excision was complete, which we've just learned. Okay, so then there's a bunch of coding, right? And this is the staging coding. So this is from a slightly different case, and I'll tell you what each of the little letters mean. If there's a Y in the front, it means that this is post-neoadjuvant chemotherapy, so or radiochemotherapy. So it means the tumor's been shrunk down. So it means that this coding wouldn't have been the coding of the tumor at the start, but it's what was left after the initial treatment. P means a pathologist is making the statement. So PT3 means the pathologist has seen that the tumor goes down into the subserosal tissue, the pericolic tissue. It's gone through the submucosa. But then P, the pathologist says the nodes are a 1B. So a 1A is 1 to 2 nodes, and a 1B is, I think, 3 to 4 nodes. So we have several lymph nodes involved. The C means clinical. So the clinical investigations showed that there were no metastases, M0. So that is a stage 3B under the AJCC 8th edition classification. And here we have that there were also 2 small tubular adenomas, a well-differentiated carcinoid tumor, and mismatched gene deficiency was not identified, meaning that this tumor probably arose through the APC pathway. And that will influence its treatment, as we will see in a couple of slides. So let's think about what ancillary tests can be done. There's usually, in a lot of tumours these days, there's a bunch of ancillary tests that are either reported at the time or as a supplementary report for the tumour. Okay, so ancillary studies, immunohistochemistry for mismatch repair gene products. So immunohistochemistry is where we look on the surface of the cells for proteins, and we find the proteins normally present for the 4 mismatch repair genes. So these are present and normal, indicating these genes are being made normally. So their mismatch repair will be working. This one has got a BRAF. So the BRAF is a gene, and they're looking for a specific mutation, a mutation at 0.600 where the amino acid V has been changed to the amino acid E. But it's wild type. This means that this mutation is not detected either. So wild type means no mutation detected. All right, they might have wanted to go and look for MLH1 promoter mutation directly, but as these are normal, then they've not done it, so it's not tested. Okay, a different way to find out whether these people have an abnormality in DNA mismatch repair is to look for microsatellite instability. It is more sensitive but much more expensive than doing these protein tests with immunohistochemistry. So they did that, and it's MSI stable, which confirms the immunohistochemistry result. So there's no microsatellite instability. We're finding the normal proteins. It's basically saying that this tumor did not arise through the DNA mismatch repair pathway or methylation of the promoter. Okay, then they're looking for a RAS gene, and it's also wild type, so it's not mutated. So remember KRAS in the pathway. So why do they look for mutation of that? It's because some chemotherapies are ineffective if that gene is mutated. Okay, and they didn't do any markers on the neuroendocrine neoplasm that we found, the little carcinoid tumor. Okay, so what next? You have some homework to do due by the 7th of March. It's on CuraCloud. Remember, if you did find all this confusing and you have forgotten what you learnt in last year, you can do the CuraCloud pre-work, and that will help you remember the basics. And then when you look at this, you will be able to pick up the extra points and successfully interpret pathology reports. Thank you.